So the next topic is on clinical insights on use of dapagliflozin across ejection fractions. It is, of course, in combination with the ARNI. So I'll just come down to the conclusion itself. In conclusion, this trial in routine clinical practice, the initiation of ARNI and SGLT2 therapy led to significant improvements in the health status of heart failure with reduced ejection fraction patients and contributed to improved ejection fraction. Patients with heart failure with improved ejection fraction experienced a better quality of life at 1 year in comparison to the other group. Additionally, heart failure with improved ejection fraction was linked to better overall outcomes. So it is recommended that all heart failure patients undergo the Kansas City assessment because it is an independent predictor of patient outcomes. Yeah, so I think, of the four pillars, SGLT2 has definitely established its own place, which wasn't the case only 5-6 years ago. Only difficulty I find with this particular drug is majority of the female patients within a month or two, especially if they are above the age of 55, 60, do get recurrent urinary tract infection. And in my own practice, almost 50% of the female patients discontinue the use of SGLT2 inhibitor. Surprisingly, some of the elderly men also experience higher incidence of urinary tract infection. So though I was very encouraged and enthused about this, but in the real world, I find almost dropout rate of at least 30 to 40% in men and above 50% in women. Now, so I'm a little disappointed, and that is why this is the last of the drugs that I add to the heart failure patient. Majority of my patients actually are not getting SGLT2 inhibitors unless they are very young. So I made these comments simply because we've got 4 experienced cardiologists here, whether they share similar views or how they handle this kind of a problem. Yes, Dr. Dilip, I would like you also.
So we beg to differ on this particular aspect. We don't see that much of UTIs, and maybe the reason is we have got counselors for heart failure, and the patient is counseled about the hygiene and basically the genital hygiene is very important here.
Yeah.
And also previous history of UTI. So we screen the patients properly. We advise them, and then we have a counselor which tells us about the genital hygiene, and that's why our in our practice maybe the dropout rate is, I think, very negligible, very negligible. I tell you, maybe it's a kind of outlier what you got, but if you counsel I know you people are busy operating patients, but your juniors or your heart failure coordinators, if they can counsel the patient, the things can change. So Dr. Kalyan Raman and Dr. Nishant, what is your dropout rate of SGLT2 inhibitors in male and female patients?
In my practice, there is no actual dropout. Most of the patients, they follow ARNI and SGLT2. But some patients, we have to reduce the dose of ARNI because of the hypotension. Sometimes we have to reduce from 100 milligram to 50 milligram, or even half of 50 milligram. Most of the patients, they are followed and the EF improves. They're happy with the treatment, even though it is slightly costly.
But Nishant, about UTIs with SGLT2, what is your experience?
There are two kinds of things. One is the local fungal infection, which is dealt by keeping a proper hygiene. The other thing is recurrent UTI. I find mostly if there is an elderly male, there is something like BPH, which is causing residual urine, and that is causing UTI. And if that is taken care of, the chances of UTI again becomes negligible. In females, especially in heart failure, once you restrict the fluid intake, then it becomes a little difficult because fluids, as endocrinologists say, 3 liters should be given with SGLT2. But in heart failure patients, we usually recommend 1 to 1.5 liters. So that is an issue. But on a basis, when we follow up these heart failure patients, what I usually do is to follow them with a KFT and a urine routine microscope to see the pus cells in their urine. So if the pus cells are becoming more, we are alarmed just before the UTI is presented. So you can start SGLT2 and after 2 weeks you can call with a urine routine microscopy, and that really helps. If the pus cells is 2 to 4 or less than 5, that means the patient is tolerating it very well.
Perfect. I think, yeah. So this study is also regarding those patients who improved on ARNI and SGLT2 inhibitors and how were their experience, and it shows those patients with heart failure with improved ejection fraction, they also had got better KCCQ score on these drugs.
Do you see any difference in the diabetic population versus non-diabetic as far as UTI is concerned?
Yeah, obviously, diabetic patients were more careful, and obviously the chances were a little higher.